Welcome, everyone. I'm your moderator, Dorothy Sears, professor and executive director, at Arizona State University's College of Health Solutions. I'm also co-lead of the Cancer Prevention and Control Translational Team. My breast cancer-related interests are community engagement and support, recurrence prevention, and enhancing survivorship outcomes related to insomnia, cognition, and quality of life. I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions at ASU. Our college works to address the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These Health Talks are one of the ways that we serve the community with timely and relevant education information that also provides continuing education credit at no cost. Before we begin, I have a few quick housekeeping items. First, this session is being recorded and will be posted on our website, asuhealthtalks.com. After the panelist presentations, I will moderate a Q&A session. We'll have about 20 minutes for Q&A. Please submit your questions using the Zoom's Q&A feature and not the chat box. Please register your attendance using the self-check-in link posted in the chat so we have an accurate record of who attended today's webinar. Finally, you will receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, this must be completed in order to receive the credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. So at this time, I'm so excited to introduce today's speakers. First is Dr. Lida Mina. Dr. Mina is a senior associate consultant with the Division of Hematology and Medical Oncology and chair of the Breast Cancer and Gynecological Disease Working Groups at Mayo Clinic in Arizona. Dr. Mina has more than 40 publications and a special interest in developing new treatment strategies for metastatic breast cancer. Dr. Mina will be followed by Dr. Brenda Ernst. Dr. Ernst is a hematologist and oncologist with a comprehensive cancer center at Mayo Clinic, Arizona. Dr. Ernst has served in various roles in education and research, having been the most recent program director of the fellowship. She plays an active role in a large portfolio of investigator and industry-directed clinical trials. Her research interests are driven by her passion to enhance representation and access to clinical trials that improve the care and medical knowledge for patients with breast and gynecological cancers. Our third and final presenter is Ashley Plum, my friend and now collaborator. Ashley is a triple-negative breast cancer survivor who took her experience and turned it into something positive by becoming a breast cancer advocate and the executive director at Check for a Lump, a local breast cancer nonprofit here in Arizona. We are so fortunate to have these health experts here with us today as we explore updates in breast cancer treatment and research. The success of yearly Breast Cancer Awareness Month in October can lead people to feel that they know breast cancer, but doctors, practitioners, and patients understand that there is always something more to learn about breast cancer treatment and research. In today's webinar, you will get up to date on new therapy strategies, such as antibody drug conjugates, vaccine and cell therapies, and PET-based initiatives. Our first presenter is Lida Mina with a presentation titled Updates in Triple-Negative Breast Cancer. Dr. Mina, take it away.
Thank you. Thank you for having me today. It's really a privilege to present on this platform. I'll be talking about updates in triple-negative breast cancer. And I will basically try in the coming 10 to 15 minutes to give a quick background and then a little bit of highlight on what's happening in both early stage as well as metastatic disease. So as you all know, 15% of breast cancers diagnosed worldwide are triple negative. It is a heterogeneous disease highly aggressive. It is chemotherapy sensitive, but it quickly leads to development of resistance. The problem with triple negative, it's high risk of early recurrence, usually within the first 5 years. And unfortunately, when it metastasizes, it metastasizes to visceral dominant disease or even brain metastatic involvement. Once it's spread, there is a short median survival of about 2 years. And if you look at the graph over here, in orange is like the triple negative breast cancer, and that's compared to other types of breast cancer, and that's the recurrence after a patient presents and had her surgery. So as you see, with all other breast cancers in general, we do have a higher risk in the first 5 years, but it's basically much lower compared to when we talk about triple negative and the risk of it recurring in the first 5 years. Treatment for triple negative has always been chemotherapy up until just the past few years. Then when immunotherapy was introduced, and we'll talk also about the antibody drug conjugates. So whenever we are dealing with early stage triple negative breast cancer, we are talking about stages 1 to 3. And the general approach has been, we do prefer starting with systemic therapy, even prior to actually proceeding with surgery. And that's in general, because we believe that the response to chemotherapy actually matters, and it will give us a good sense about what we are actually dealing with. So the mainstay of treatment for early stage is actually chemotherapy in combination with immunotherapy. And as I mentioned, we start with it even before surgery in general, because we are relying on what we call pathologic complete response, or the response, to tell us how our patients are going to be doing and their prognosis. So whenever we start with what we call neoadjuvant treatment, which is upfront treatment prior to surgery, in general, with all types of cancers, patients who achieve what we call a complete response or respond really well, they do dramatically better than patients that do not respond well to the upfront treatment. But that response and its relation to prognosis is specifically when it comes to triple negative, where you can see that those do not have any overlap, which basically tells us from the beginning that tumors that are resistant and do not respond, unfortunately, lead to a much worse event-free survival when compared to tumors that actually respond. So our newest introduction to treatment on top of the regular chemotherapy has been what we call immunotherapy or checkpoint inhibition. And those are basically drugs that release the brake on the immune system and try kind of to get the immune system to help in fighting the cancer itself. We only have at this time one drug that's approved for triple negative breast cancer, and that's pembrolizumab, an anti-PD-1 drug. However, we are seeing that a lot of very interesting studies with the durvalumab that we expect soon approval with another anti-PD-L1. So those are kind of the main drugs. Pembrolizumab specifically was approved in early stage breast cancer triple negative based on the Keynote 522 study. And this is basically patients that are newly diagnosed triple negative, that have early stage, a little bit on the higher risk, more than 2 centimeter with or without lymph node involvement. And basically they were randomized to either receiving our old classic chemotherapy with carbotaxol, anthracycline based, versus actually the chemotherapy, but with the introduction of immunotherapy. And all of this happens prior to surgery, and then we continue with the immunotherapy. A pretty extensive type of regimen. However, it led to an improved overall survival benefit in early stage triple negative breast cancer. And that is what led to the approval actually of immunotherapy, and specifically pembrolizumab, in this patient population. However, early stage triple negative breast cancer is not one disease. So not all triple negative breast cancer will need immunotherapy. We know that some tumors that are much smaller size might need much less. We know that patients who have a genetic mutation might need a little bit of a different, maybe not now, but we are having a lot of studies looking into specifically BRCA specific triple negative. And we are also looking into biomarkers that hopefully can tell us which patients actually do need less than this very highly extensive type of regimens. Moving on to metastatic triple negative, and that's a stage 4. Again, the mainstay of treatment is immunotherapy and chemotherapy. Metastatic triple negative breast cancer is unfortunately most of the time incurable. However, we've come a long way, and immunotherapy has been moving us waves and waves in the right direction. So it's not as dim as it was before, but we're nowhere close to getting where we need to be. Again, with immunotherapy and chemotherapy, another one of the newest studies that got approved, again, the same drug in the metastatic setting, is the Keynote 355 that looked at the introduction of immunotherapy with chemotherapy, and it can be any type of chemotherapy. And that's randomized to either the regular chemo versus introduction of immunotherapy. And again, that led specifically in tumors that have a PD-L1 positive defined by more than 10, that led actually to improved progression-free survival as well as overall survival. Unfortunately, immunotherapy comes with a price and has quite a bit of toxicity. We're talking about dermatitis, GI toxicity, fatigue, thyroid problems, adrenal insufficiency, and can rarely but potentially be fatal if our immune system attacks lungs, pneumonitis, or heart with myocarditis. So we are still basically having a lot of challenges because not all patients benefit from pembrolizumab. And even with the introduction of pembrolizumab, overall survival is still too short. And our testing is still very limited with the way we test for the PD-L1. Moving on to beyond chemotherapy and immunotherapy, we have the new, what we call the magic bullet antibody drug conjugate, which is basically an antibody that's a targeting device that's linked with a linker to a drug, that's the payload. And the whole point is to allow to deliver actually toxic drugs, but in a more targeted version. So the antibody drug conjugate would be selectively going to the antigen that ideally will have to be more expressed on the cancer cells versus normal cells. And then it's internalized to the early endosome, leading to the degradation of the ADC, release and action of the payload, with also a little bit of a bystander effect that helps with the surrounding of those cancer cells. So there is a lot of antibody drug conjugates that are currently in development. As far as breast cancer is concerned, currently we have 3 drugs approved. However, we're moving more and more towards more approved. Only the first one that was approved was anti-HER2, which is the TDM1, but now we have 2 drugs that are finally approved in the triple negative breast cancer stage in the metastatic disease. The first one is called sacituzumab, an anti-TROP2 that's specifically designed. It was the first in class TROP2 directed antibody drug conjugate. And based on the ASCENT study that was specifically done in triple negative breast cancer, they compared this ADC to regular chemotherapy, and it showed a marked improvement in what we call progression-free survival, but also an overall survival benefit, which led to this drug being approved in triple negative breast cancer. Moving on to the last part, triple negative breast cancer disease is not one type of disease. Now we know that within that group, there is what we call the HER2 low or the ultra low that is considered triple negative. However, the cancer cells still have a little bit of an expression of what we call HER2. So in triple negative breast cancer, we call it triple negative because we don't have good targets. So all the research is trying to find targets on those cells, and a little bit of HER2 on those cancer cells can potentially help with leading us to find a more targeted drug. And the drug we're talking about is called trastuzumab deruxtecan. That was first approved specifically for HER2 positive, but now it's also approved in the triple negative breast cancer, specifically in those triple negative that have a little bit of HER2 low. This was approved based on the Destiny Breast 04 study, where they looked again at just classic chemotherapy versus giving the TDXD drug, and that was significantly causing marked improvement in progression-free survival and overall survival, actually more than doubling. So this drug helped specifically in what we know is also triple negative breast cancer, although the group of patients that was studied here was a little bit on the smaller side. So to summarize, we have a lot of newer drugs making their way into the triple negative breast cancer. We start with chemotherapy, immunotherapy, we move to antibody drug conjugates. We always want to know the germline mutation because that opens up a group of treatment that's related to PARP inhibitor, which I'm not addressing here. But basically, this is our usual approach with this disease. We try again to test for the PD-L1. We try and know what we're dealing with, chemotherapy, immunotherapy, and then moving on to the antibody drug conjugates. On that note, I would like to end and leave the floor to my colleague, Dr. Ernst, who will be talking about a lot more exciting stuff coming up. Thank you.
Fantastic. Thank you so much, Dr. Mina. I just want to say, if you haven't done so already, please register your attendance using the self-check-in link posted in the chat so we have an accurate record of who attended today's webinar. Next, we have Dr. Brenda Ernst with the presentation titled Innovations in Breast Cancer Treatment. Take it away, Dr. Ernst.
Hi, and it's a pleasure to get to share some of these exciting things with you today. I am going to try and be brief and succinct and still keep us on time. So we'll take it away with that. These are my disclosures. Nearly all of what I'll discuss is off-label as we're still trying to understand how to apply best practices learned from other tumor types with regard to immunotherapy and immunotherapy strategies in breast cancer as a new horizon. So whenever I talk to a patient about treatment or research in general, I want to drive down the point or the goal of the approach we're going to take. And it doesn't matter what stage I meet a patient, it always beckons back to the same mantra. The right treatment for the right patient at the right time is where we're going to find success. Treatment should always be evidence-based, but in general, we're finding that an individualized approach is going to lead to an improved outcome. And that generally is through better diagnosis and leading to a higher cure rate in the patients that we find at earlier stages. Better treatments reflect prolonged life and better quality of life on treatment, and in patients with metastatic disease, that may be a long time. So the optimal detection and precision of these therapies is important. The kind of breast cancer that a patient has is going to really determine strongly the kind of treatment we use, and in some cases can forgo. And so I want patients and their family members, caregivers, and in the breast cancer community to think of breast cancer tumors as being unique to patients. So not any other breast cancer is alike. This graphic on this slide is really representative for one reason. When I look at it, I get a little bit overwhelmed as I see the various subtypes of breast cancer. And what it reminds me is there are unique qualities inherent to each individual tumor, but that we can overlap certain characteristics to create subtypes so that we can tailor therapies and research directives to a particular category of breast cancer for better determination and impact. We know that there's different types of breast cancer. Dr. Mina suggested, the application to what we previously termed triple negative breast cancer and now understand characterizes also ultra HER2 low or HER2 low. But that's probably the tip of the iceberg of what we understand about triple negative breast cancer. And I would suggest there's much still to be learned in hormone positive and HER2 positive breast cancers as well. So a lot of what I'll talk today about is related to immunotherapy. And just in case we have a diverse group of learners or interested parties in the audience today, I'll distill this down to immunotherapy being the use of the body's immune system to help recognize and fight cancers. Through the recognition of breast cancer cells, the immune system then learns about their presence and can use that to attack cells and patrol for future cells. So this will involve the portion of T cells that identify an antigen or the signature of a cancer cell, and then can present it to other cells for activation and recognition. Those cells can be marked for destruction, and that gets activated through cytokines, granzymes, and other chemicals within those domains that are lethal to the cancer cell. Immunotherapies come in different flavors. There are multiple kinds of immunotherapies. We certainly in 10 to 15 minutes won't go over much of that today. In the frame of breast cancer, we'll direct our memory to trastuzumab and pertuzumab, which are monoclonal antibodies directed against HER2. We oftentimes forget about these as immunotherapies, but they're probably part of the earliest immunotherapeutic strategies where we used an antibody memory cell-based response to target a HER2 aspect of a breast cancer cell and manipulate that for tumor control. There are other targets like PD-L1 that Dr. Mina spoke about, I'll briefly mention as well, and CTLA-4 that are in the checkpoint inhibitor category. And there's also many targeted available areas to direct cancer vaccines. We're becoming more familiar with adoptive therapies like Sipuleucel-T and others that are specific to breast cancer in greater development. There's a trendy discussion in the last years around cell therapy or CAR T therapies, and that fits under the heading of immunotherapy. Briefly, I like to think of CAR T therapy as a form of an adoptive therapy, where we use the synthesis of smarter cells derived from a patient's own immune system that can be better targeted towards the cancer or disease that we hope for them to fight. They can be delivered into the body to affect the function and programming of the immune system towards the cancer. And so I'll briefly mention a few of those opportunities in our trial portfolio today as well. Briefly, how it works when we think about the checkpoint inhibitors that Dr. Mina was discussing about relate to manipulation of what our body sees as a security guard. Just like many functions in our body have a safety on and off button, our immune system does as well. So that's through the function of something we call checkpoints. Checkpoints function to make sure that we don't overactivate our immune system to destroy the rest of our normal tissue or excite an extreme inflammatory process. That can be considered like a criminal that enters into a building, being able to fake out the security guard by pulling out a fake badge. So cancer cells can utilize PD-L1, which will bind to the PD-1. Usually the building's immune system response would set off an alarm. But that binding of that PD-1 and PD-L1 says, calm down, don't worry, I'm a friend, and lets the criminal in to be undetected or not allow the typical alarm systems to go off. And so checkpoint inhibitors play a role in our cancer treatment by removing this opportunity for criminals or cancers to be unnoticed within our immune system. In a different domain of the immune system, Adoptive therapies and vaccine therapies are directed at the T cell receptors. This is an antigen interaction that activates the immune system, leading to expansion and immune cell destruction through activating these granzymes and other lysis activities, but also allows the body to have memory of that process so that in the future it can patrol against future cancer cells that may drive resistance or recurrence. When we think about the application of immunotherapy to breast cancer and cancer in general, we have to understand it's a dynamic process. So, identifying one of the areas to manipulate the action of the immune system against cancer is very important. Checkpoint inhibitors representing one of those considerations. But that alone, particularly in breast cancer, has not given us the success that we would hope to achieve with potential for cure or ongoing surveillance with less recurrences. We recognize that the immune system has means to be activated in various elements, sometimes with higher adverse effect rate, but also with the consideration that the cancer cell is itself a dynamic process that has means to overcome our applications. So when I think about immunotherapy, I always remember the place I'm trying to make an intervention is where I expect the action to occur, but downstream from that, I can have both adverse effects related to where I'm targeting, but I can also have the resistance of the cancer cell after the pressure of my intervention has been applied. We primarily have seen immunotherapeutic strategies, both in the setting of CAR T cells, vaccine-based therapies, and checkpoint inhibitors, playing a larger role in luminal B breast cancers and basal type breast cancers. And so I think there's much still to be learned about applying the immune system to our hormone positive or cold type breast cancers. And I won't be able to speak about that today. Much of our content is applicable to those types that I mentioned. Adoptive cell therapy that I reflected is the category that we find vaccine therapies, chimeric antigen receptor T cell therapies or CAR T cell therapies, and tumor infiltrating lymphocytes. It's referred to as cellular therapy, and they usually involve directly isolating immune cells, expanding those in numbers, and altering these cells to genetically enhance them and return them to the patient. In the setting of CAR T cells, we anticipate that a patient will have a target that is known on the cancer. Then the patients will usually have cells removed through a process we call leukapheresis. Those cells in the form of a laboratory environment will be taught the target, enhanced sometimes through genetic mechanisms to increase their fighting ability, and then returned to the patient. We usually have to decrease the immune system's response through chemotherapy before receiving these, much as you would a transplant. And then we're able to observe and monitor for the response in the tumor, but also for the potential adverse effects of releasing these enhanced immune cells into the body. In the setting of tumor infiltrating lymphocytes, this information is derived through a patient's tumor-informed knowledge, and then that is used to enhance a off-the-shelf lymphocyte driven product that is directly related to that patient's tumor, and then it is delivered back to them. And so for patients that are getting TIL therapy, they do not go through an apheresis process. We do have approved CAR T cell therapies in diseases such as leukemia, lymphoma, and myeloma. And we also have tumor infiltrating lymphocyte therapy that's been recently approved for treatment in melanoma. We don't have either of these therapies available for treatment in breast cancer, and currently their applicability to breast cancer is in the research setting alone. So I'm just going to give you a brief overview of the trials that we have here at Mayo, Arizona, and in your community that we are applying these therapeutic strategies to patients. CAR T therapy, as I mentioned, involves removing the white blood cells, which include the T cells, from the patient's peripheral blood, and then in the laboratory, doctoring those to tumor-specific antigens, and then delivering those back. It involves a pretty robust process, and patients through this CAR T therapy are oftentimes requiring some hospitalization or very close oversight for immune overactivation that can be a downstream effect of CAR T therapy. When we have seen its applicability in leukemia and lymphoma, we have oftentimes seen considerable improvement in the burden of the cancer, and in certain instances, cure that would come from prior refractory tumors. So we are excited about the opportunities that these hold for breast cancer. However, understanding their role in solid tumor is still yet to be declared. One of the trials that we have here open at Mayo, Arizona, and I lead this trial, is with the agent LYL797. This is RO1 targeted therapy, and it is directed towards triple negative breast cancers. This ROR1 target is enhanced and found in triple negative subset of breast cancer approximately 50% of the time in our experience. We have had several patients that have been treated on this trial, which is open nationwide in a few centers, and we have seen some good on-target effects. We have also seen some challenges related to the overactivation of the immune system, and understanding how to best escalate this therapy for patients' benefit is still being determined. There are other ongoing breast cancer relevant clinical trials that are open nationwide with regard to CAR T. And I think this is an opportunity that we will see come into play, hopefully, with more effectiveness and lesser toxicity in the years to come. When we think about cancer vaccines, the mechanism of cancer vaccination is to provide the target antigen so the immune system can learn it, recognize it, and then patrol for that in the future. The immunostimulatory molecules that are activated through dendritic cells can also facilitate migration to lymph nodes, and understanding of that in the lymph nodes can create memory of the immune system against future activity. There's two approaches to cancer vaccines we see: treatment vaccines and prevention vaccines. And treatment vaccines have an ongoing area of the immune system to engage with so that their activity can be monitored over time. Prevention vaccines are largely about immunopatrol, protection, and recognition. I won't belabor this, but we have had a long history in the development of cancer vaccines that date far beyond 1950, but with the introduction more so in 2010 and to the future that we're seeing now, with the representation of Siplucel-T, which is a dendritic cell patient-derived vaccination therapy that is given to patients with prostate cancer for an on-treatment activity. We are seeing more therapeutic strategies utilizing this mechanism and its applicability in breast cancer research as well. At Mayo Clinic, we have a vaccine program that is targeting the areas of prevention. Patients before they develop even the earliest stages of breast cancer, called Artemis. This is derived through plasmids and DNA priming for historical reference from patients that have had breast cancer before it ever develops, as well as stage 0 DCIS, which has been introduced in the Florida and Rochester sites and has yet to come over to the Arizona location. But I'm going to focus on our current trial in HER2-positive breast cancer that is open for patients with stage 1 through 3 breast cancer, and recognizing there'll be a strong pipeline to come. A phase 1 multi-epitope HER2 vaccine. This looks at antigens that were derived from multiple prior breast cancer samples in the HER2 domain. And on the phase 1 study, 22 patients enrolled and received a series of vaccination after their HER2 therapy completion, and they were followed to monitor their response. The patients that received this therapy had minimal adverse effects. There was one patient that had a drop in their ejection fraction that is central to the HER2 activity. And the patients overall were able to be seen for the following 2 years with good memory and reflection of T cells that were detectable with the HER2 specific cellular domain recognition after this vaccination. And so 90% of the patients that received this on that study developed HER2 specific CD8 T cells. And with that, the phase 2 study that is ongoing at our center was open and funded by the Department of Defense to look at this in a greater population in comparison to placebo. A word for precision guidance in treatment is very helpful as we understand how to apply the various targets that we would harness the immune system in our directed therapies. But not all directed therapies will be immunotherapy in nature. It's important that we understand the genomic landscape. So oftentimes we are getting genetic sequencing on the tumors that are taken from patients in the earlier stages of therapy so that we can give a targeted approach or a more precise approach to their patients. We can also use this information to understand the resistant patterns and, and direct that to the individual in front of us. So if a patient is developing progressive disease and we can understand that they developed a certain mutation that is known to show resistance to a certain aspect of our treatment, that might tailor our therapy in that direction. Finally, clinical trial guidance can utilize this precision information both in immune targets as well as non-immune targets for better selection of candidates, like the trial that I was reflecting earlier, which uses the ROR1 target that we know is present on certain triple-negative breast cancers and activates the immune system against that target. We would not want to apply that trial indiscriminately with a high level of toxicity, albeit with also a high opportunity for benefit in patients that would have that target if they didn't have that target to say that the risk was worth it. We can also use precision medicine or analysis of this genomic landscape to get a better understanding of treatment response. And so finally, I will just reflect to you the two applications of two studies that are looking at this in an example of precision-directed clinical trial opportunities for patients. The Tracy study is one such that we use a PET-driven assessment of a tumor marker. And if a patient is using that screening that is done through imaging to link a radiation particle to a somatostatin receptor, which is the target of this therapy, those patients can be identified where their disease is present through the use of a screening PET modality. And if those patients have that activity on their tumor, there is much more likely to have a predicted response. That study is called the Tracy study, and it'll soon be open at our Center for Patients with Metastatic Disease. This implies that in this instance, the PET scan is the screening modality to find the target, and we're using that radio-labeled particle to identify where the target is in the patient. On the opposite end of the spectrum, we have the Stop HER2 study, understanding better the way that the HER2 target functions within patients with breast cancer and through therapies, similar to some of the excitement that Dr. Mina discussed, but also reflecting back to the 20 or 30 years that we've had trastuzumab and pertuzumab available in our domain against HER2-positive breast cancer. We understand some patients will have such a robust response, even in metastatic or end-stage disease, that they may be able to discontinue therapy in what was previously determined an uncurable space. And so this trial, the Stop HER2 trial, is open nationwide, and it is available for patients that had been treated in the first line with an exceptional response to HER2-targeted therapy and should be considered for discontinuation with close monitoring on imaging and circulating DNA to assess even up to 10 years whether or not these patients are able to remain off therapy. I appreciate the time, and I know I probably ran a little bit over, and I'll be glad to answer any questions if they come up at the conclusion of our session. Thank you very much.
All right, thank you very much, Dr. Ernst. So now we will move on to Ashley Plum's presentation, our last presenter today. Her title is called Survivorship, Advocacy, and Check for a Lump. Ashley.
Sorry about that. Couldn't find my unmute button there for a second. I want to thank everybody for attending and being willing to listen to me. I'm not a doctor. I don't have any medical expertise, but I am a survivor and an advocate, and I am the executive director of Check for a Lump now. So before we kind of dive into some of the other things that I want to talk about, just real quick about myself, I had triple negative breast cancer, stage 2B, in 2017. I did chemo, carbo, and Taxol 12 rounds, and then AC for 4 rounds. And then I had my double mastectomy and reconstruction. I had a PCR, and I am now 7 years NED. So super excited for that, to be able to share that news this October. So I love when I see the charts and then it keeps going down and down and down, and I'm down at the bottom down there now. So that always is exciting for me. So survivorship is different, can mean different things to different people. It could mean, support groups, new friends from cancer, doing something different in your life, getting involved. At Check for a Lump, we welcome all breast cancer survivors and their co-survivors to get involved. And as you can see in these pictures, all of these women in these pictures, with the exception of the Girl Scouts down at the bottom corner, are breast cancer survivors and are involved with Check for a Lump in some way, shape, or form. And they're all just like super excited to be part of what we do, and to keep going with their survivorship. And we have such a wide variety of survivors, and we always tell anybody that calls us that they're a survivor from the day that they're diagnosed. So I hope that you guys all share that as well. Because I feel like for me, when I was told that by my breast surgeon, it really made a difference, because it just gave me that extra little boost of hope, to kind of get through everything. Survivorship from diagnosis, like I just spoke about, and then during treatment, you're surviving treatment, you're going through all the things, and then you have your recovery time, and then maybe you go and you join a support group, or maybe you've done that from the very beginning. Not everybody joins support groups, and that's okay. And then there's post-treatment too, because post-treatment, we love our doctors, but they're like, okay, you're done, goodbye. And we're like, wait, I don't know what to do without seeing you all the time now. So that's where Check for a Lump kind of steps in, and then your friends that you went through chemo treatment with as well. Getting involved is very important to me. I knew I wanted to do something different with my life rather than what I was doing before, but didn't know exactly what it was other than getting involved with the world of nonprofits. And then in 2018, I was an honored WIG client through Check for a Lump, because I received my WIG during treatment through Check for a Lump. So I went to the Wig Out Gala. That bottom picture down there is me with a couple of our other survivors and WIG clients, and then the founder of the organization as well. After that, I was just truly inspired by all the things that Check for a Lump was doing, not just the WIG program, but all the things. And so I participated in the Pink Out 5K that fall. Luckily, they don't require you to run, because I'm not a runner. So it's a lot of fun. And then I just started to volunteer. And then in 2020, prior to the pandemic hitting, I came on board as the outreach coordinator. And then pandemic happened and we shut down for a while. But then when we started to ramp back up, I was volunteering again, and then came on board officially as the director of development at the beginning of 22. And then in 23, in April 1st, no fooling, I became the executive director at Check for a Lump. And so with that, when I started back up in 22, I really started to dive into advocacy, representing patients in their healthcare journey, working to improve the lives of people with breast cancer, attending cancer educational conferences like AACR or the NBCC Project Lead. I'm also going to the San Antonio Breast Cancer Symposium in December, so I'm looking forward to hearing about all the new things there. And then just, being a representative of women who have had breast cancer, to bring it back to you guys, in the education world, in the research world, so that you can know how we feel as survivors, how we've gone through treatment. So, working side by side with other survivors, whether they are DCIS early stage all the way through metastatic. So that way I can share their experiences, with the researchers and with doctors that are working on new treatments. And then fighting for changes in cancer policy, and supporting survivors during and post treatment. So I do a lot of things, but I do it all with a huge passion, and now I get the privilege of spending my days helping women just like me. A little bit about Check for a Lump. So our vision is to make a difference in the fight against breast cancer, and our mission is to provide free breast health education, mammograms, testing, and direct assistance to breast cancer patients with wigs, support, and resources in Arizona. We have 4 pillar programs. Our education program is we have a magazine that is full of prevention tips and tricks, information about our programs, survivor stories, and all sorts of other fun things. So you can get that on our website, checkforalump.org. It's digital, or you can reach out to myself or anybody at Check for a Lump, my whole other 2 staff members. And we can always mail you a magazine if you would like. We also do our Step Up to Prevention presentations. They're like a lunch and learn that we offer to groups or businesses. And we have a podcast and, of course, our website and all of our social media stuff. And then we also have our mammogram program. So we offer free screening mammograms to uninsured women, or also underinsured. So like if they have insurance, but it won't cover their mammogram for some reason, then they would qualify for our program. And then should they need any follow-up diagnostic testing, we'll cover that until an all clear, which we're always hoping for, or until diagnosis. And if they are diagnosed, we refer them out to other groups within the state of Arizona where they can get their treatment. We also offer new wigs to breast cancer patients who are going through chemotherapy. That offer is available to any woman in the state of Arizona, regardless of income or insurance, because even if you have insurance, it doesn't necessarily cover it. Even though it can be considered a prosthetic, some insurances don't consider a wig during chemotherapy as prosthetic. They consider it a temporary cosmetic thing. And good wigs are expensive. So we cover the cost up to $300. They get to go to a local wig shop that we partner with and pick out a wig that looks just like them, just like I got to. So it's pretty cool. And then we have our support tier. It has 3 different things underneath it. Actually, one of them is missing from my slide I see here. But we offer our Super Survivors Unite, and it's just a group of breast cancer survivors and co-survivors can come and get together, and we just do fun stuff, whether it's arts and crafts, or we learn a new fun recipe that's healthy, or we do easy yoga. We've done some sound healing and some learning about essential oils. Looking forward to one next year that we're going to have. It's all about talking about sex during and after treatment, because it's rough sometimes for people. So, that'll be a ladies only night. But we welcome all the different co-survivors, and a co-survivor for us is anybody who was with you during your journey. It can be your spouse, it can be a caregiver, it can be a relative, it can be a friend, it can be your kid, your grandkid. We've had all sorts of different people come. And then our Super Survivor kits are filled, there's a bag full of items that we've curated as survivors who work at Check for a Lump, and things that we found comfortable during treatment. And we deliver those for free out to women going through breast cancer treatment. We also have a list of resources in our magazine and on our website. And then we also have a Girls Night Out, which is part of a Second Act, which is another nonprofit that we took over part of. And so those are open to all women cancer survivors, but it's only women, it's only for the ladies, but it's any cancer it doesn't matter what kind of cancer. And then, so that's me in a nutshell and Check for a Lump. And so if you want to learn more, you can scan that QR code, or you can go to checkforalump.org. And I love to share about this picture on this slide. all of these women are survivors, and they've all had different stages of breast cancer. None of them right now are currently, none of them are metastatic. But then this was last year during Phoenix Fashion Week, and this year we actually had 2 metastatic women who walked the runway, which was really cool. So we had even more diversity representing women and breast cancer. So thank you, and I'd be happy to answer questions during our Q&A.
Fantastic. Thank you so much, Ashley. I had a great time at the Wig Out Gala. It's in March usually, right? I don't know. You have the date set up, Ashley, but it's so fun. And everybody, even the men, wear wigs to this gala. It's super fun. All right, so we'll move on to questions. So I'm going to start with a question that is for Dr. Ernst and Dr. Mina, depending on how you feel about who should take it. So is it common practice to check biomarkers in all triple negative breast cancer tumors?
I can take this one. So when we say biomarkers in breast cancer, the main biomarkers are the ER, PR, HER2, and that's like the basics. But when we look for more extensive, which is basically what we call genomic testing, or more biomarkers like the HER2 to see if it's low or ultra low, in general, we go down that path if the breast cancer is a stage 4 or metastatic, because up to this point, early stage disease, unfortunately, we don't know too much beyond the ER, PR, HER2 as far as tailoring treatment. But as far as like all the trials, yes, we do biomarkers. Whenever it's metastatic, we do biomarkers from the get-go and repeat it on a very regular basis. And when we say biomarker, we're talking more of like the genomic testing.
And a follow-up to that was, is for somebody who has had triple negative breast cancer in the past, should they ask for biomarker testing? And then that gets to my next question. So, I see
So
you shaking
no,
your head.
unless I mean, there is a concern for metastatic disease.
Mhm. And if I may, I'll take the moderator's privilege of asking a question, a sciencey question, and that is, could you speak to the status of liquid biopsies for breast cancer? So taking some blood samples and looking for tumor DNA and or microRNAs that might help in prognostic indications or treatment.
Yeah, I think that's an area of evolving understanding on how to apply those tests. We know that they have good application thus far in metastatic disease monitoring. It's been seen across various strategies to look for a specific mutations present at the time of maybe a clinical trial's delivery of an interventional treatment, and then they'll reference back and see whether or not a change in that mutation presence or absence reflects the action of the intervention. We have not seen it come into mainstream for looking at DNA as a means to survey patients, but I think it's on the horizon. We do have available laboratories that are doing these tests, like through Signatera, and those things are coming to us as questions from patients as to, should I, have these tests done at various times of my treatment or to determine steps in my therapy. And I think our team is also becoming more familiar to how to apply that information, but it's not yet at this status that I think it's being widely used. And so I generally will use that strategy on clinical trial only. Another consideration, though, in that question was around liquid biopsy for genomic landscape or understanding of the presence or absence of a target. And that might be at a particular point in time to say, I need to make a treatment change. Should I go in a certain direction or not? And we utilize that strategy very frequently. But we have not yet taken that approach to looking at the change in the dynamics of certain aspects of the tumor DNA, though that research ongoing.
Thank you very much. As a trained molecular biologist, I'm really excited about that pathway for the future. Okay, so here's a question from the Q&A. The question is about the metastasis of breast cancer to the peripheral nerve system and the central nerve system. So the question is there any progress on preventing nervous system spread?
Lida, do you want to answer that with your therapies you spoke about today, kind of in that space?
Yes. So the brain and specifically like the CNS and spine has been like very problematic because most of our drugs unfortunately do not penetrate what we call the blood-brain barrier. So it's been like the biggest challenge. Having said that, we have come a long way with the newer drugs. So the couple of drugs I talked about, the antibody drug conjugates, we are seeing now that they do actually penetrate the blood-brain barrier. So we have seen that patients who are actually on those drugs have lesser risk of developing metastatic disease specifically to the brain. Even taking it to another level, there are small tyrosine kinase inhibitors that we are currently using in a clinical trial now that are oral medication, smaller molecules that we are using in patients who have metastatic disease, specifically in the HER2 metastatic setting. And basically, we kind of give the patient the option of being on those smaller molecules that we know penetrate the blood-brain barrier to prevent brain mets. But it's very challenging because none of those drugs, I mean, goes without side effects. So it's a very tight balance between like, you know, how much we want to be very aggressive in this scenario.
Thank you. All right, Ashley, we have a question for you. How do you support men with breast cancer, trans folks with breast cancer, and non-binary folks with breast cancer? Because the comment was that your presentation was a little bit gendered in the language. So just want to talk about your the way your organization is open-minded and open in the way you serve all people.
Yeah, and you know, first let me apologize for making it so gender focused because normally I'm better about that because we do support anybody. I mean, granted, the majority of all of the people that come to us are women. But we don't discriminate. We welcome anybody, you know, any gender, non-binary, it doesn't matter, any ethnicity or race. We welcome anybody and everybody to come to our organization if they need help. We actually specifically on this latest magazine for this year, we did a couple pages on men with breast cancer and like what they should be looking for in their statistics as well. So because I know even though it is, you know, it's rarer than women with breast cancer, it still happens. So we definitely want to support that. And if we had more people that could come to us, you know, that are in those categories, and we would welcome them. And then if anybody in this group knows more about male breast cancer or non-binary or transgender or anything like that, and I would welcome conversations you know, offline about that so that I could just educate myself more on it so that way we can, you know, facilitate better for those groups as well.
Fantastic. Thank you. All right. And then the last question is, scientifically, is it possible for a subject or patient to be cured of breast cancer for the lifetime or long-term survival?
I think that is highly possible, and maybe much of the reasons people like myself and Dr. Mina are drawn to give the kind of care that we provide, not only to patients that we enhance their life with metastatic disease, but hopefully most of the patients that we will continue to find and diagnose with breast cancer at an earlier stage with a high likelihood of cure. I think maybe at the heart of that question may have been, and I'll, you know, got on a limb, is there a potential for patients that have had spread of their disease to obtain a cure in the current era of breast cancer treatment? And I think we all have seen the unique case that gives us hope and opportunity for patients to have their disease become stabilized and not return. But I would say that those are very far and few between, even with our best available therapies right now. If that has been in my career seen, it's typically been seen in a patient with a low volume of HER2 positive disease where we have very good knowledge and I would say coverage of the target on that cancer type. And I think in the future, we may have the opportunity through the immune therapies that we discussed and those that we're probably yet to better understand to harness a chance for cure in various breast cancers. But currently, if patients are diagnosed with stage 4 disease, we usually will anticipate treatment at various elements of their disease for the life of that patient. And our goal is really to optimize the time that they have with their disease to be as long as possible. And I usually carry that very closely to another statement I tell patients while they live as well as possible. And we have really nice therapy that Dr. Mina spoke about earlier and others that weren't able to be presented today that allow patients to live with metastatic disease well, but unfortunately not long enough for many.
Thank you so much. All right, well, that's all we have time for today. If you've not already done so, please register your attendance using the self-check-in link posted in the chat. We encourage you to follow the College of Health Solutions on social media. Note the social media channels on the screen so that you can learn about other opportunities like this one. Our Health Talk series will continue on November 21st. It's a monthly program. The topic will be Compassionate Journeys, Hospice, and Palliative Care for All Ages. Details and registration are available at asu@healthtalks.com. Thank you again, speakers and attendees, and have a great rest of your day.